worldwide, accounting for more than 1 million of cases in the last year, in 2012, after breast, lung, colon and rectum and prostate cancer. Cancer in general is associated with several risk factors, and in the case of skin cancer, it is associated with the exposure, with skin tone, fair complexion. People with blonde or red hair are more prone to develop skin cancer. With people with a weakened immune system and with family history. Indeed, skin cancer is more frequent in white people when compared with black ones. And in Europe, the South countries like Portugal, Spain, Italy, and Greece are those that present higher number of cases of skin cancer, maybe due to the higher exposition to UV radiation. Cancer in general developed through several steps, including initiation, promotion, and progression. The skin cancer starts with normal epidermal cells that are initiated. In the initiation occurs an irreversible DNA damage in a normal cell, transforming it in an initiated cell, in a mutated cell. After this, during the promotion, the mutated cells divide in an uncontrolled way, leading to the development of benign lesions, namely papilloma. In the last step, progression, the benign lesions are converted into malignant lesions due to the accumulation of more genetic alterations. The carcinogenesis, the skin carcinogenesis may be studied in the lab, so animal models may be used to study this type of cancer, and the initiation may occur after the administration of a carcinogen agent, namely the dimethylbenzotracene, N-methylenitrosarray, cisplatin, or after exposition to UV radiation. Promotion may occur after the administration of the carcinogenic agent TPA. TPA is considered a promoter, while the MBA or HEMINU are considered as an initiator, and promotion may also occur after the exposition to UV radiation. Animal models have been frequently used to study different diseases, including cancer, and mice and rats are among the most frequently used animals due to several characteristics, namely, their physiology and genetics are well known, they are easy to maintain when compared with other species and easy to manipulate, they are relatively cheap. The most important one, they are mammals and have many similarities with humans in terms of their anatomy, physiology, genetics, and biochemistry. Talking a little bit about intense pulsed light. Intense pulsed light is a non-laser light with intense pulses of non-coherent light and a wavelength ranging from 500 to 1200 nanometers. Intense pulsed light apparatus may be easily purchased by anyone and used at home without any supervision. Although the effects are not fully known, it is known that several adverse effects may occur due to the use of these apparatus, namely pain, edema, vesicles formation, infections, scars, hyper or hypopigmentation. Despite this, the long-term effects of the non-supervised use of these apparatus are not known. Clinically, intense pulsed light may be used on the treatment of different health problems, namely vascular lesions, pigmented lesions, hypertrichosis, epidermal atrophy, dermal atrophy, acne, rosacea, and also in the treatment of actinic keratosis, unwanted hair growth, scars, angiokeratoma, non-melanoma skin cancers, and may also be used to skin rejuvenation. Now this work aimed to assess the effects of intense pulsed light exposition in healthy skin and skin with paraneoplastic lesions, and for this a mice model was used. Materials and methods. Animals were acquired from a certified company. The protocol was approved by the Portuguese Ethics Committee, and animals were maintained under controlled conditions of air filtration, temperature, humidity, light-dark cycle, and fed with a diet ad libitum. 28 ICR mice were randomly divided into 5 experimental groups. One group exposed to the DMBA, the initiator agent. One group exposed to the initiator and treated with the intense pulsed light. One group exposed to both initiator and promoter agents. And two groups used as control. One group control without exposition to chemical carcinogens or IPL, and one group only exposed to IPL. Here we can see the experimental protocol. At the beginning of the study, animals from groups DMBA received an application of the promoter, of the initiator agent. After this, animals from DMBA and IPL group were treated with intense pulsed light 2 times a week, receiving 2 pulses. And animals from DMBA and TPA received the TPA, the promoter agent, 2 times a week during all the experimental protocol. At the end of the experiment, animals were sacrificed, blood samples were collected directly from the heart. Animals were sacrificed by overdose of pentobarbital sodium, followed by exsanguination by cardiac puncture, as indicated by Felada. Skin samples were also collected and were used for biochemical analysis or immersed in formalin for histopathological analysis. Results and discussion. Concerning to the animal's body condition, we observed that the final body weight and ponderal weight gain was lower in animals treated with both carcinogenic agents, the initiator, the DMBA, and the promoter, TPA. Concerning to the interleukin and C-reactive protein levels, in the immunoblotting analysis, we observed that exposition to the DMBA and or IPL increased the serum levels of interleukin 6 and C-reactive protein when compared with control groups. This increase was more evident in animals exposed to both agents, the initiator and the promoter. We also observed that the serum levels of total protein and albumin were lower in groups exposed to the DMBA and EPL, and in the group exposed to the DMBA and TPA. The alanine aminotransferase serum levels were higher in the MBA and TPA group when compared with control group, and an increase in the activity of aspartate aminotransferase was observed in groups DMBA and DMBA plus IPL. Here we can see some of the macroscopic lesions developed by the animals. The first lesion was detected at the 50th week of the experiment in the group exposed to the promoter and initiator agents, the TPA and the MBA respectively. Concerning to the microscopic lesions, at histological analysis, hyperplasia, papilloma, and squamous cell carcinoma were observed. Hyperplasia was observed in 3 animals from the group DMBA plus IPL, and whole animals from the group DMBA plus TPA developed hyperplasia. 5 animals from the group exposed to the initiator and the promoter developed papilloma, and 3 of these animals developed squamous cell carcinoma. No lesions were observed in the groups DMBA, IPL, and control. Here we can see a histological cut of the skin of the DMBA group, and a negligible and diffuse mononuclear infiltrate was observed. Here, a histological image of the skin of the group DMBA plus IPL, focal hyperplasia and mononuclear inflammatory infiltrate in the dermis was observed. Concerning to the group DMBA and TPA, this group developed not only hyperplasia but also papilloma and squamous cell carcinoma. A total of 87 papilloma were identified in this group, from which 54 were grade 2 papilloma. 7 squamous cell carcinoma were also identified. Here we can see the histopathological image of the grade 1 papilloma on the left, of the grade 2 papilloma on the right, grade 3 papilloma and squamous cell carcinoma, all of them belonging to the group DMBA and TPA. In the group IPL, we observed a dermal fibrosis, and no changes were observed in group control. Concerning to the Western blot analysis of the skin samples, the ATP synthase and gut pH levels were higher in groups exposed to DMBA or IPL when compared with control group. Concerning to the ratio ATP synthase and gut pH, it was lower in groups exposed to IPL and or DMBA when compared with control group, suggesting that DMBA and or IPL exposition promoted metabolic remodeling of the skin towards a glycolytic phenotype. The higher levels of P53 and caspase-3 were observed in groups exposed to IPL or DMBA, supporting the theory that the metabolic changes of the skin were related to an increased susceptibility to apoptosis. Nitrate proteins and carbonylated proteins were higher in animals exposed to IPL or DMBA, suggesting that the skin metabolic remodeling was paralleled by increased oxidative stress. Several isoforms of keratin, alpha-keratin, cytoplasmic actin-1, and beta-actin of type 2 were among the proteins more susceptible to oxidation. The identification of keratin and actin among the most susceptible proteins to oxidation suggests that the biological processes of organization of the cytoskeleton and apoptosis underlie the adaptation of the skin to IPL exposure. Conclusions. The results of this work suggest that EPL exposure promotes inflammation, changes the metabolism of the skin, increases proteome susceptibility to oxidation, being more significant when IPL was applied in skin with neoplastic lesions. Here are two papers that we published with this work. I would like to thank to all people and institutions that contribute to this work and share with you some images of the Alentejo, of the University of Évora and City of Évora, that is patrimony of UNESCO. Thank you very much for your attention.
Thank you very much, Dr. Anna, for your excellent presentation. Do anyone have questions regarding this PPT? Okay, it seems there are no questions. And thank you once again, Dr. Anna, for your nice presentation. Thank you so much.
Have a nice day.
Yeah, you too. And we will move on for the next keynote presenter. Who is going to speak on the prevention of impending scalp or necrosis by topical nitroglycerine and hair transplant surgery. Dr. Zahir Abbas, who is a board-certified dermatologist and who practices currently in dermatology and cosmetic center at Muscat, Oman. He acquired his doctorate degree of medicine from the Tehran University of Medical Sciences. He went ahead to get his specialty training in dermatology and completed his residence program in year 2014 from Razi Hospital, which is at Tehran University of Medical Sciences. It is the most prestigious training center in the field of dermatology in the Middle East region. He has researched and wrote many articles in his field, and he is a member of Iranian Society of Dermatology and International Society of Dermatology. His interests are serotic dermatitis and psoriasis, dermatology, and cosmetology. And I would like to call upon Dr. Zahir Abbas to start his presentation now. Thank you very much. Dr. Zahir, we can see your screen, but we cannot hear you. Can you please unmute your microphone, please? Uh, Dr. Zahir, can you hear me? So we cannot hear you. So we can see your screen, that's it, and we cannot hear you.
Hello, can you hear me?
Yes, Dr. Zahir, now we can hear you. Yeah. Okay, please go ahead. Yeah.
Thank you so much.
You're welcome.
Hello, dear colleagues. I am Dr. Zahir Abbas. I'm a dermatologist in MG Dermatology Center, Muscat, Oman. I hope you are staying safe during COVID-19 pandemic. And first of all, I would like to thank United Research Forum who provided me this opportunity to be with you for a few minutes. And I am going to present my recent study that is published in the Journal of Cosmetic Dermatology, Prevention of Impending Scalp Necrosis by Topical Nitroglycerine in Hair Transplant Surgery. So first of all, we go to introduction. As you know, hair transplant is a relatively safe surgery and is associated with very few complications. And one of the very devastating complication is recipient site necrosis. So this event can have many bad and cosmetic and psychological outcomes for the patient and also medico-legal implication for the surgeon. So therefore, surgeons should be familiar with this complication, its preventive measures and management strategies. As you know, recipient site necrosis usually occurs as a result of vascular injury, and circulation in the scalp is marginal, particularly in the central and frontal area of the scalp, and there are very few perforating veins. And on the other hand, there is a very reduced vascularization, particularly in the patients with androgenetic alopecia. Unfortunately, there is a paucity of literature on the incidence of recipient site necrosis as well as potential treatment options due to market issues. So most of the time, necrosis can be avoided by careful planning, but sometimes we have to face this necrosis irrespective of considering all preventive measures. Therefore, this is very important to look for new preventive and therapeutic options to meet with such a challenging issue. There are many risk factors that predispose a patient to recipient site necrosis. So some of them are patient related, including smoking, atrophic or photo damaged skin, scarring of recipient area, history of scalp surgery, diabetes mellitus, particularly the long-standing or uncontrolled, and extensive baldness, older age are the risk factors that are related to the patient. There are some risk factors that are related to the technique itself or related to the surgeon. That are dense packing, mega sessions, large openings, deep incisions, sometimes infection, and high epinephrine concentration, although this matter is controversial. So topical nitroglycerine has been used in the prevention of tissue necrosis following mastectomy skin flaps. It has also been used, and one of the important strategy for the necrosis induced by dermal fillers. And as you know, nitroglycerine causes arterial and venous dilation and has been used to increase the perfusion to ischemic tissues. On the basis of these considerations, we presume that nitroglycerine spray may be used to reduce the incidence of this necrosis during hair transplant surgery. So our methods were, we performed a retrospective observational study to determine the efficacy of topical nitroglycerine on the impending scalp necrosis following hair transplant. 1,580 patients with androgenetic alopecia who underwent hair transplant by FUE method between 2017 and 2019 at our center were retrospectively enrolled in this study. Nitroglycerine spray was used for 88 patients who were suspected to impending scalp necrosis. We applied nitroglycerine spray every 1 hour as the black hue or bruising appeared and further grafting was stopped in the affected area. Patients were followed up at next day and after 1 week. To reduce bias and to strengthen the results regarding incidence of necrosis, we used also a control group that was from 2014 to 2017 with the same number of hair transplant cases, that was 1,580 cases. From our past record, when we did not start nitroglycerine spray at that time. Therefore, patients who underwent hair transplant before 2017 were analyzed as control, and those who after this period were evaluated as nitroglycerine group. All cases included in this study were performed by direct supervision of a single dermatologist, and all cases undergone hair transplant by a technician with the experience less than 2 years were excluded from the study. So our results were, as you can see in this slide, 88 patients who used nitroglycerine spray, 83 were rescued without any problem. So meaning that 94.3% cases were rescued by using nitroglycerine spray. The black hue or bruising that is considered a precursor for necrosis faded out within average 30 minutes of using nitroglycerine spray in most cases. But 5 patients ended up in necrosis despite using nitroglycerine, and in control group, necrosis was observed in 14 cases, that was 0.88% of the total. There was no statistical significant difference between two groups as a demographic point of view. So hereby we present some of our cases that had significant bruising or black hue. So this case was 31-year-old male with the previous history of smoking. As you can see in the picture A on the left side, there is a bruising and black hue, and we use 3 times nitroglycerine for him every 1 hour. And now on the right side, as you can see, there is no black hue or no bruising, and the patient rescued with the use of topical nitroglycerine spray. And we completed our hair transplant after 1 day when the skin was fully recovered in this area. The second case is the 33-year-old female with the previous history of diabetes, and that diabetes was also uncontrolled. And again, you can see on the left side picture, there is bruising and black hue. And this is very important to recognize this condition because if we delay in recognizing this condition, then maybe we lost the golden time of using nitroglycerine spray. And you can see in the right side picture that there is no black hue and there is no bruising in this after using 3 times nitroglycerine spray. And we use after every 1 hour this nitroglycerine application. And we completed this hair transplant in this patient on the same day because that was a little mild case of this bruising. In the third case, as you can see, there is a 37-year-old male, and he has a previous history of smoking. And in this case, the black hue is more severe, and it was impending to necrosis. But fortunately, we could also save this patient from necrosis. We use 4 times in this patient nitroglycerine, but we completed the hair transplant in this area after 1 month after full recovery of this skin area. And in this case, this is a 29-year female, and again there is a very severe black hue, and the patient came on the next day, so there was a little delay, but fortunately again we could successfully use the nitroglycerine spray. We used it for 6 times, and again because this area was little damaged, but after 2 months we finished the hair transplant in this area, and there was no scar remaining on this area. So again, the patient was survived from the necrosis. And the case number 5 is 42-year-old male, again with the history of smoking. And this is the most worst condition. You can see that this is almost near to necrosis, very severe black hue or browsing. And again, we use 10 times nitroglycerine spray. And here you can see on the right side picture that we could survive this patient also with usage of nitroglycerine from incidence of necrosis. And we completed the hair transplant after 3 months in this patient when the skin was fully recovered in this area. So coming to discussion, by accurate case selection and proper technique, often this event is preventable by experienced surgeon and trained team. But the important thing is the timely recognition of impending necrosis, because this is very crucial. And if we miss this crucial time, then the use of topical nitroglycerine is useless. Necrosis is suspected when a bluish or dark hue appears in the recipient area, and this blue area, this browse hue, resulted from the blood pooling and clotting underneath the skin, and this process prevents new blood reaching to the skin, and eventually lack of oxygen leads to necrosis. Topical nitroglycerine can induce smooth muscle relaxation in vessel wall, resulting in venous and arterial vessel dilation, and also cause endothelial cells to synthesize prostacyclin, which can inhibit platelet activation. And application of topical nitroglycerine can provide quick improvement in tissue perfusion. As you can see, we observed necrosis in only 5 cases in the treatment group. That is significantly lower than both our control group, and there it was 14 cases and 0.8%, and also Solentary et al. Study who reported it in 0.8 cases. Therapeutic failure in these 5 cases may be due to delayed recognition of black hue, vulnerable to necrosis, particularly when we noticed it on the next day of surgery and we missed the golden time of nitroglycerine's application. We use the spray from due to its easiness of use and quick absorption via slits. It can be washed readily after a few minutes to avoid side effects. Although side effects seen very rarely, but they can range from headache, weakness, hypotension, tachycardia, and mild bleeding in the respected area. As a conclusion, we propose that nitroglycerine spray may be regarded as one of the measures in the management of impending scalp necrosis. Hereby, we provide an algorithm that is very useful to avoid such condition. Minoxidil use should be before the operation. This surgery, this procedure should be used for many months before, and this will resulted in the vascular bed to increase, and also the tummy scent should be injected very slowly. Epinephrine use should be decreased, and the other way is slitting on the first day and engrafting on the second day, particularly in the high-risk patients in the mid-scalp region. Slitting and engrafting in horseshoe shape, leaving the central area on the first day, that is also, and the other option, wider density in the first day and adding grafts in the second day is also the option we can use. And if browsing seen in particular area, we should avoid engrafting till next day to give the skin to recover itself, and slits depth should be made carefully to avoid vascular transaction. Its suitability depends upon graft size, tummy scent quantity, and skin size that is different in different areas of scalp. And after recognition of dark browsing or impending necrosis, we should stop further grafting in that area and should apply nitroglycerine spray every 1 hour until bruising disappears. And in our experience, it may take 15 to 120 minutes, and we can complete the hair transplant surgery in the affected area when it is recovered fully. It may be after 2 weeks, after 1 month, and after 2 months. Thank you for your attention. And for any question, you can email me and you can ask me directly. Thank you so much.
Yeah, thank you very much, Dr. Zahir Abbas, for your nice presentation. So regarding the prevention of the scab by topical nitroglycerine, which is related to the hair transplant surgery. Thank you
Yes.
very much for your
Thank you.
this interesting presentation. So, do you have any queries for Dr. Abbas?
I want to ask him.
Yes, Dr. Huang. Yes, Dr. Huang, you can go ahead, please.
Okay, congratulations for your presentation, doctor. I want to ask you why you don't use this nitroglycerine for prevention. If you cannot do before the onset of the necrosis, why?
Dr. Zahik, did you get that question from Dr. Huang? Just a moment, Dr. Huang. He left out the meeting and he's joining with us again. So I think he missed his question. So you can ask him again. So he would be pleased to answer that. So just a moment. I think he's joining with us. Dr. Zahir, can you hear me now? Dr. Zahir? So you just got a query from Dr. Huang Mei-Ling. So she just wanted to ask you a question. So can you hear us? Oh, okay. Dr. Huang, I think Dr. Zahir cannot hear us, maybe due to some technical issues. Yeah, so maybe we can contact him via email. That will be fine. Yeah.
That's fine.
Yeah,
Thank you.
Thank you for your understanding. Yeah. Thank you. So we just we are with keynote presentations. So we have completed that. So and we'll go for the next speaker presentations. Miss Elita Nuhidiati. So she's a cost and dermatology department of Dr. Suleiman General Hospital in 2019, graduated from the Islamic University of Indonesia, and as a co-assistant in the dermatology department of the same hospital in 2019, and she is currently as an internship doctor in Bali, Indonesia. Ms. Alita, you're most welcome to begin your presentation on multi-bacillary leprosy with the nerve damage and anesthetic ulcers. Thank you so much.
Okay, thank you. Can I start?
Yes, you can start.
Yeah. Okay. First, I would like to say thank you to the conference committee for giving me the opportunity to be able to present my case report study. Good morning, everyone. Today, I will present my case report study. The title is Multibacillary Leprosy with Nerve Damage and Anesthetic Ulcer. This is the abstract. And then this is the overview that I will present today. First, I will describe the case shortly, and then introduction about leprosy, etiology and bacteriology, epidemiology, transmission and intubation period, classification, clinical feature, diagnosis, treatment, and complication. And this is the case. 48-year-old man diagnosed with multivascular leprosy. He complained of numb spot appearing blackish white that spread to almost all over the body since 1 year before admission to the hospital. Symptoms are also accompanied by appearance of nodules on the neck area. Patient also complained anesthetic ulcer on the fingertip and the toe. Physical examination was found that the patient looked moderately ill, compos mentis, blood pressure 130 per 80 millimeter mercury, pulse 19 per minute, temperature 36.5 degrees Celsius, and breathing 20 per minute. Examination of the head in supercilia, there is madarosis. There are bilateral enlargement of the nerve, that is auricularis magnus nerve, with a soft, palpable consistency and pain. I will show the picture later. And then examination of the superior and inferior extremities, there is atrophy of the intrinsic muscle with anesthesia on the right and left. The dermatological status in this patient was in the generalized region. There were hyperpigmented anesthetic macule with multiple size diffuse and soft squamous. The patient was treated with multi-drug therapy for 12 months. 1 a month. On day 1, patient get rifampicin 600 mg, clofazimine 300 mg, and dapsone 100 mg. Once a day. On day 2 until day 28, patient get clofazimine 50 mg and dapsone 100 mg. And this is the introduction. What is leprosy? Leprosy is chronic granulomatous infectious disease caused by Mycobacterium leprae, mainly involve the peripheral nerve and skin. Other organ may involve like mucus of mouth, upper respiratory tract, eyes, bone and muscle, thus common involve every organ except CNS, ovary, and lung. And this is bacterial characteristic. Mycobacterium leprae is gram-positive obligate intracellular bacillus due to its large pool of non-functional genes. Acid-fast stain with modified Pfeiffer stain or ZN stain. Short, thick, pink stain road of size 5 micro by 0.5 micro. Occur characteristically in clump or bundles. And Mycobacterium leprae grows best in colored tissue like skin, peripheral nerve, anterior chamber of eye, upper respiratory tract, and chest, sparing warmer area of the skin like axilla, groin, scalp, and middle of the back. Optimal time of growth is 30 until 33 degrees Celsius. And this is background discovery. Leprosy discovered by G.A. Hansen in 1823, first bacterium to be identified as causing disease in man. Treatment only appeared in 1940 using bromine. Many countries in Asia, Africa, and Latin America with a significant number of cases. About 1 until 2 million people disabled due to past and present leprosy who need to be cared for by the community. And this is epidemiology. Leprosy can occur in all age, from early infancy to very old age. Youngest age report as 1.5 months. And leprosy can occur in both sex, male or female, 2 by 1, and it's equal in Africa. Global prevalence rate is less than 1 case per 10,000 person, elimination achieved in 2000. And this is transmission route. Actually,